There's been enormous progress in the fight against malaria over recent years, and we've all heard of that. And since 2010, between 2010 and 2016, the number of pediatric deaths were reduced by around 35%, which sounds like great news. But the tragedy is there's still 285,000 children died in 2016 of malaria needlessly because the therapies are available. And so it's really important that in addition to developing therapies, we get the drugs that are available now to those in need. Children with severe malaria can also, if they don't die, they can also have severe debilitation, particularly neurological effects. And this can affect education. It can simply keep them out of school, particularly with relapsing vivax malaria, for example. So the impact goes far beyond mortality. There's been a focus over the last 10 or so years on pediatric medicines, and in 2007 the World Health Assembly issued a resolution for better medicines for children. In 2009 we saw the first essential medicines list for children, which was 32 years after the creation of the list for adults, but it was an acknowledgement that children need particularly tailored developed medicines, and there's simply not many adults, as you've already heard. The Better Medicines for Children campaign promoted child-friendly medicines, the need to meet dosing, tolerability, and ease of administration, very much what Bernard was just telling you about. It's also about the caregivers. So in 2009, the EML included the first dispersible artemisinin-based combination therapy. So this is a gold standard ACT therapy for the treatment of malaria. It subsequently included another one, and just to give you an illustration of the challenges that these medicines are trying to overcome, I mean, you can see below a child being administered something that clearly is not friendly. And so you may get it into a child, but it won't stay there. There's another issue we need to take into consideration, and that is that as we develop these medicines and make them available, and I think to summarize what we've heard from our Unitaid partners over the last days, you can develop a compound, but unless it gets into the mouths of those who need it, it's not a medicine. The unfortunate thing is the medicines that are often getting to patients today are poor quality medicines. They're not quality assured. We actually don't know in many cases what they will deliver and what benefit, if any, they will provide. So this is the scene in what is a traditional drug shop. When MMV was formed, it was formed to address what was a market failure in the development of anti-malarial medicines, and this was our portfolio when we were formed back in 1999, and this is the portfolio today. So just a couple of important points. If you look right across at the column on the far right, these are the launched medicines. So there are medicines that are saving lives today. 2 of those medicines were developed by our sister organisation DNDi, and they've been incorporated into this malaria drug portfolio. The rest of the portfolio looks quite rich, but we all know that drug development is risky and a lot of these projects are going to be failing. Taking into account the fact that 2/3 of those who die from malaria are children less than 5 years of age, our entire development program must focus on the needs of children from the get-go. And so we do this in 2 ways. We work with our partners to ensure the first formulations that are developed are child-friendly, not the second or third formulations that are developed. The next thing is that when we get into what are called phase 2B studies, so the first studies of a combination in patients, we're already going into children. So we start with adults in a first cohort, we go down to adolescents, and once we have safety data, we quickly begin going down until we get into younger cohorts of children. That allows us to progress towards registration. So in the first registration of the drug, it will include children for pediatric use. Now, working with our partners, a number of drugs have been approved and have been included into the essential medicines list for children, and you can see them listed here. You can also see that there are generic versions of these becoming available, so this is the good news. Some of this is challenging, and I'll just make a very quick point about pediatric dosing. Coartem, for example, Novartis has done a superb job working in partnership to develop the pediatric dispersible formulation, and that is having a huge impact with around 350 million courses of treatment distributed. If you go right down to the neonates, though, that formulation begins to behave differently because they metabolize the two drugs because it's a combination differently. So if you were to give that to the very youngest of children, the newly born, they'd either be overdosed on one or underdosed on the other because the two drugs don't behave the same in a newly born child. And this illustrates some of the complexity. In terms of impact, you can see 4 drugs that we've developed in partnership here, and you can see some of the impact that they're having. And what's really important about this impact is the commitment of our partners to make these available at an affordable price, to ensure that they're widely available, and then for other partners, such as Unitaid, President's Malaria Initiative, Global Fund, to support in both procurement, but in the programs that allow adoption and support adoption and familiarisation of the products in country. And so my final point, just to nail a few of the key messages, Bernard gave a superb reflection, and I think that these also highlight some of his points. We, as drug developers, need to stay focused on the needs of children, particularly in disease areas like this, where it's children that bear the brunt and are the most vulnerable. Second, our procurement partners, it's really embrace the prioritisation of child-friendly medicines. We can't continue dosing with fractionated doses of adult medication. For practitioners, we need to ensure that they have availability, but they're also trained in the use of these medicines. Not all of them are easy, and so with training, some of those barriers can be overcome. And the final thing is public health guidance, and that's really to ensure that we get timely approvals and timely policy setting so that these can be adopted and used by children as rapidly as possible, because there's nothing more heartbreaking than developing drugs like these for children when the final barriers of effectively the rubber stamps and the policy adoption is trailing, because it means those children don't get access to the medicines that they sorely need. So thank you very much.
Great.